internal medicine resident at St. Luke's in Bethlehem, Pennsylvania, and I am happy to present this short video for the ACUI student lecture series. This is not comprehensive, but hopefully a good starting point for some of the most common encounters you will have on night float. So this is called the top 10 pages you'll get on night float. Probably the most common thing you'll ever get texted about is that it's night and the patient can't sleep. In general, hospitals are a terrible place to sleep because there's a lot of noise, there's a lot of vital checks, you're getting your labs drawn at 4 in the morning, the beds are not comfortable, you may be sharing a room, so it's very hard to sleep in the hospital. You should do everything you can to make it as pleasant as possible to sleep in the hospital. So if they don't need labs at 4 in the morning, don't get labs at 4 in the morning. If they don't need their vitals checked every 2 hours, try and minimize that overnight as much as you can. Keep the door closed, let it be dark in there. So that's just in general for every patient. That won't work for everyone. And so often your first go-to will be melatonin. It is in general very well tolerated, very safe for patients, very few true contraindications. Is it effective? It's not super effective, but it's in generally very well tolerated. So we start with that. Another thing to check on is make sure that anyone who has chronic insomnia, that their home medications are continued. A lot of people will have some of their medications stopped on admission, and if they were continuously taking something at home for sleep and you've stopped that on admission, they're going to have a very difficult time sleeping. Lastly, if you tried all the other things, you can try low-dose antipsychotics like trazodone, mirtazapine, doxepin. They can be a little bit sedating and help people go to sleep. There is not a lot of robust evidence for this, so this is really only if the patient is really upset, wants to try and go to sleep and needs something to do it. It's not something that should be standard for all patients. And then lastly, things that you don't want to do. Benzodiazepines and anticholinergics are on the Beers list of medications to avoid in the elderly. They can be sedating. Some people will try and use them for sleep, and generally you do not want to use benzodiazepines or anticholinergics for sleep, especially in the elderly. They can cause a lot of delirium, sedation, and a lot of other side effects, especially with anticholinergics. One of the second most common things you'll get called about is pain. And this is a very broad topic. So just breaking it down into if this is part of what the patient came in for, they came in for abdominal pain, you know it's because of a specific etiology. You can go ahead and treat that pain. They should have as needed medications as well as usually scheduled medications. And if you schedule medications as much as possible, particularly non-opioids, you can usually reduce the use of opioids. So things like Tylenol, gabapentin, lidocaine, if appropriate. You can schedule those medications, help patients sleep through the night, help their pain be controlled rather than peaking and needing more as-needed medications. For as-needed medications, you want to make sure you know what you're treating. So again, knowing what's causing it. If it's their admission diagnosis, that's completely fine. But if this is something unexpected, you need to investigate it a little further. So new pain, unexpected pain, changing pain, or pain that's suddenly changed in proportion, all those things should be red flags that something else is going on. I shouldn't just give pain medications. I need to go see the person, figure out what's going on, and then treat the pain. And then just overall, NSAIDs are typically something that we avoid in the hospital. Most patients have some degree of renal dysfunction or some other contraindication, cardiac disease, AKI. There are some exceptions, like a young, healthy person with a kidney stone, but in general, NSAID should not be one of the first things you reach for pain. Family update. This will often happen. You're in the middle of doing 7 other things. You may have an admission. You may be even called urgently to a patient's bed, and then you'll get a text that, oh, this patient's family is here. They weren't here all day. They'd like an update. And at nights, you're often cross-covering 40, 60, 80 patients. So you don't really have the time to dig deep into everyone's chart, figure out what's going on, and give the patient's family non-urgent updates. So what I'll typically do is if this is just truly a non-urgent update, I'll defer that to the day team, say, look, I'm covering many patients at night. I can tell you that there's been no change during the nighttime, but I'll leave the day team to update you more fully about everything that's going on in the long-term plan. So At nights, you really have to think about addressing urgent things first, and then typically a non-urgent update is not going to be something you're going to have time for. If something does happen on your shift, there's a fall, there's a stroke, there's a seizure, anything where you actually do need to go to the bedside, you're adjusting medications, things like that, it's always a good idea to give family a call, update them about those sort of things. But non-urgent updates you can typically hold off on. Delirium, very common, especially during night shift. Also known as sundowning because it happens when the sun goes down. So if you're on nights, you'll be seeing a lot of this. You need to make sure that this is truly delirium. It's not something like a stroke, seizure, some sort of primary neurologic disorder manifesting as altered mental status. But if you do identify that this is delirium, you want to reorient the patient as much as possible. In general, like we were talking about with sleep, you want a good wake sleep cycle. So help them sleep as much as possible during the night, stay awake during the day, avoid unnecessary awakenings at night. Um, and you really want to do non-pharmacological interventions as much as possible. You want to see what's causing delirium. Delirium can have many, many precipitating factors: infection, medications, constipation, urinary retention, hypoxia, hypercapnia, pain, especially uncontrolled pain, metabolic abnormality. So you really want to see what is causing this delirium and treat the underlying cause as much as possible. That could be something like if they're having acute urinary retention, addressing that. If they're having any of these metabolic abnormalities, addressing that. If they're having uncontrolled pain, treating their pain a little bit better. If you've gone through all of that, you can't do anything more about treating the underlying conditions. There can be a role for chemical constraints or physical constraints if a patient is a harm to themselves or a harm to others, but you really want to avoid these if at all possible. If you really need something, typically you'll do something like a second generation antipsychotic like Zyprexa. But again, these are something you want to try and avoid if at all possible. So do everything else first. And this is really only if the patient is in danger of harming themselves or someone else. Fever. Can happen a lot in the hospital. So any patient who is in the hospital for a known infection and they're receiving appropriate treatment with antibiotics, it's typically not a big deal that they have a fever. Things like pyelonephritis, you can have fevers for like 48 hours, and still be getting appropriate treatment. So in those cases, you would just give Tylenol or other antipyretics, especially if the patient's feeling uncomfortable, and just try and control that fever. That being said, if you have a fever in patient who does not have a known infection, you need to evaluate them, figure out what's going on, seeing if they're stable or unstable. If they're stable, you need to figure out what's causing this. It could be infection, it could be a non-infectious cause. There's a lot of drugs that can cause fever. So if it's a completely stable patient, you have no reason for this. You can monitor, see if it comes back again. If you think there's a suspicion for infection, you begin an infectious workup. If you think there's a drug contributing to this, like Precedex is a common drug that causes drug fever, you can discontinue that drug and then continue to monitor. That's if they're stable. If they're unstable, obviously you need to do a little bit more, a little bit faster. So then you begin an infectious workup. You begin treating the instability, which is often fluids or oxygen, and you want to give antibiotics in a broad spectrum pretty quickly. This is probably going to be sort of a sepsis picture, and we'll talk about that more in the other video. But in general, fever by itself is not a problem. Just make sure you know what's causing the fever. Asymptomatic hypertension. You will get this a lot overnight. Patients will have elevated blood pressures anywhere from 140s to 180s to 200 systolic. The first thing to do is figure out why they have an elevated blood pressure. And that's a recurring theme you'll see is figure out what's causing this and then treat that rather than treating just the number. So if a patient's having horrible left foot pain and their blood pressure is elevated at 170, you treat the left foot pain that's causing the hypertension rather than just giving a blood pressure medication. If someone has elevated blood pressure and no known precipitating cause, you need to look for end organ dysfunction. That's the difference between hypertensive urgency and emergency. So some of the most common are cardiac damage, so chest pain, elevated troponin, EKG changes, Renal things like AKI, decreased urine output, and pulmonary edema, hypoxia. If those things are not going on, there's usually not an indication to treat hypertension because it's asymptomatic. And there have been multiple studies showing that using PRNs to treat asymptomatic hypertension in the hospital actually leads to worse outcomes overall. So the focus should be on long-term blood pressure control, not just giving a PRN to get someone's number below a certain number. Some exceptions. So if they're in the hospital for a primary vascular problem, things like a stroke, aortic dissection, MI, then you do often need strict blood pressure control, and that should be something that you get hand out or sign out about what their blood pressure goal is and what medications to use for that. If you do need to use as needed medications, some of the most common ones are IV beta blockers such as labetalol or hydralazine. Bradycardia, very common overnight. Everyone's heart rate slows down as they sleep. So if their heart rate is borderline before and they go to sleep, there will be a lot of bradycardia overnight. This is typically noted on telemetry, so patients will be asleep, their heart rate will go to the 50s, 40s, and you'll get a page about this. If they're sleeping, it's pretty much that they're going to be having asymptomatic bradycardia, which is not something you really worry about as long as it's sinus. So you want to check telemetry, check whatever caught this instance of bradycardia to see if it's sinus bradycardia, if there's a sinus pause or a high degree AV block. Sinus bradycardia, you really don't worry about. Patients are sleeping through it, and there's not really an indication to do much overnight. What you worry about is high degree AV block. So things like Mobitz 2 or a complete heart block. And in that case, you want to stop things like beta blockers, calcium channel blockers, and if it's something like a complete heart block or a high degree AV block, have pacing equipment available in case you need to electrically pace them. Symptomatic bradycardia, not something you really see a lot overnight, but again, if they're in one of these high degree AV blocks, you may see that, and that you have the ACLS guidelines to follow. First line is typically atropine, and you may need electrical pacing if they do have a AV block. Hypertension. Your blood pressure naturally goes down when you sleep. A lot of patients have blood pressure on the lower side, especially if they have chronic comorbidities such as heart failure or cirrhosis. So determine the degree of hypotension. Is this someone whose systolic went down 5 below their baseline and it's not really an acute change for them? It's when they're sleeping, there's no end organ dysfunction, and it's because of their long-standing cirrhosis, then you don't really have as much to do. If it's someone whose blood pressure is normally pretty high and they've had a sudden drop, that's obviously a lot more concerning. Some of the most common causes in the hospital are hypovolemia, whether someone comes in dehydrated or whether we dehydrate them in the hospital with diuresis. Medications, especially patients on multiple blood pressure medications, can get hypertensive. Sepsis or cardiogenic shock are more concerning etiologies of hypertension. So typically, you'll treat hypertension with fluids. Crystalloids and balanced crystalloids are usually your go-to. So things like lactated ringers. Colloids, obviously, if there's something like hemorrhagic shock, you need to be giving blood as well. Also, things like cirrhosis after a paracentesis, you can sometimes use things like albumin, but typically lactated ringers or normal saline is a good go-to as fluids. And you can give a little trial of fluids to see if their blood pressure responds. If they are fluid responsive, you can typically give enough fluid to get them up to a normal blood pressure. If they are not fluid responsive, then they will probably need some other agent. That may be a call for something or of mechanical circulatory support or pressors, typically a higher level of care like the ICU. Sepsis, again, we'll talk about this a little bit more in the other video, but if they are septic, you want to give them a lot of fluids because that helps stabilize them initially. You want to get blood cultures and then antibiotics. Patients often get upset in the hospital for a variety of reasons. It's no fun being in the hospital, as we talked about with sleep. In addition, you're getting fed a lot of medications all the time. So you'll often get told the patient wants to either leave the hospital or doesn't want to take a specific medication. The best thing to do is go meet with them, listen to their concerns, and try and figure out a way to address their concerns so that they are getting what they want in a way that helps their health as well. So for medications, there's often alternate routes. If it's something that's not really necessary, you can say, hey, just hold off on that. We can skip it for now. So things like Tylenol, probably not something that they really need if they really don't want it. Things like antiplatelet therapy after a recent stent, they really probably do need that. So you talk with them about how risky it would be to forego that, and patients are usually pretty reasonable about things like that. Patients sometimes want to leave, whether it is because they don't enjoy what's going on in the hospital or they really have something outside that they want to get to. It can be a wedding, they want to see family around the holidays. People will sometimes just say, like, I want to leave, I want to go home, spend this time with my family, and that is their right. So just make sure that the patient does have capacity, they understand the risks and benefits of leaving, and then helped ensure as safe a discharge as possible. This in the past has been called like leaving against medical advice. There's a move away from that term towards patient-directed discharge. In general, you want to set things up so that even though they're leaving before you think it's the best time for them to leave the hospital, they have the safest discharge. So if you're doing this at night, you want to look through what the day team was planning and ensure that all those plans are set up in terms of medications, follow-up, things like that. The day team can address some of that in the daytime, but you really want to set up as much of that as possible so that they have a safe discharge. And then if it is a problem that's chronic, let the day team know so that they can change things. So if they really don't like Tylenol and they have scheduled Tylenol, discontinue it or let the day team know so that you can remove that stressor from the patient. Nausea, another very common call in the hospital, for a variety of reasons, whether it's primary or secondary to other drugs they're getting. Some of the most common things we'll give for nausea are Zofran and Reglan. Both of them can be given IV, which is especially important with nausea and vomiting. However, they do have some degree of QT prolongation. You have to be concerned in patients who are on multiple antiemetics. Multiple QT prolonging medications, such as psychiatric medications, are often QT prolonging, or patients who have an inherently prolonged QTC. So just in general, if you're going to be giving someone a lot of antiemetics, you probably want to get a baseline EKG just to figure out what their QTC is and have an idea of how much room you have. Tygan can be an alternative if you are concerned about prolonged QT. In specific cases, in such as chemotherapy-induced nausea and vomiting, other things like that, there are other options like steroids, benzodiazepines, but typically you're working with Zofran, Reglan, things like that. And then just make sure that you know, as with all these things, what is causing this. So if they're in here for gastroenteritis and they're having nausea, you know it's from their gastroenteritis. If you have a patient who is here for a primary complaint of cellulitis and they start having nausea, you really want to figure out why they're nauseous now. Is something else going on, like a small bowel obstruction? Acute coronary syndrome can present as nausea and vomiting, especially in patients who are diabetic, elderly, female. Abdominal infections can cause nausea. So just really understanding why they're nauseous rather than just treating nausea without knowing what's causing it. That was it. If you have any questions, please feel free to contact me.